Minnesota. And our intent here is to bring some experience from clinicians, administrators, and University of Minnesota professionals to share with you what they've learned from having to deal with COVID-19 already in their clinics and in their workplaces. I will be moderating. My name is Dr. Mary Owen. I'm the director of the Center of American Indian Minority Health, and I am also a family practice physician for the Fond du Lac Nation in Duluth, Minnesota, or Cloquet, Minnesota, around Cloquet, Minnesota. I do want to read a disclaimer for the purposes of this event. I want to remind our audience that any statements made during this event are for the purposes of improving care for Native American patients. Unless they state otherwise, each panel member is speaking of their own experiences and not for their institution or tribal government. If you're a reporter, we do ask that you contact us before writing up any articles on this event today or using the words from the event. We understand that you might write about it, and that's fine, but we would like to clarify anything that's stated today, and are particularly sensitive that we are not speaking for our tribal leaders, tribal governments, or institutions. I want to also introduce our co-host, Dr. Michele Allen. She will be taking the questions and answers. I'll be reading questions that we've come up with that we thought might be helpful for the group, but Dr. Allen will take your questions, which we hope that you will enter into the question and answer portion on the, should be on the bottom of your screen. There's an option there. If you don't see that option, remember you can always enter your questions into the chat as well. We will, at the end of the webinar today, we will ask you a question on whether or not you found this was helpful. And if you did, please respond so, and also include any questions that you'd like to see on further discussions, and any people that you feel have been left out as far as the panel members that you'd like to hear from. So we have a pretty diverse panel, and I'm going to ask each of them to introduce themselves, where they work, and what they have seen or what they've been dealing with as far as COVID-related incidents in their clinic or their workplace. And we'll start with you, Dr. Allen. You're at the top of my screen.
So I'm Michele Allen. Honored to be here. I'm a family physician. I practice at the Community University Healthcare Center, and I also direct the University of Minnesota Medical School Program in Health Disparities Research. So I will be helping to moderate your questions, as Mary said.
Thank you. Dr. Sundberg.
Good afternoon, everyone, and thank you for the opportunity to join. As Dr. Owen said, my name is Dr. Sundberg's Mike Sundberg. I'm an assistant professor of medicine with the University of Minnesota. I work clinically in the Twin Cities as a hospitalist for internal medicine and for pediatrics. And then I also have the privilege of working in Rosebud, South Dakota to help provide care for the Rosebud Sioux tribe as a contract physician for Indian Health Service. So I'm really happy to be able to be here today to discuss and think about the challenges to Native communities in the COVID crisis.
Thank you. Dr. Hedberg.
Good afternoon. I'm Craig Hedberg. I'm a professor in the School of Public Health, the Division of Environmental Health Sciences. I'm not a clinician, but I deal a lot with exposures in the community. My background is in surveillance and foodborne disease response activities.
Thank you. Dr. Stately.
Yes, hi, I'm Antony Stately. I am a licensed clinical psychologist. My role and I'm the CEO at the Native American Community Clinic. And my role there primarily is as an administrator. I don't do any clinical work or direct care, but I provide oversight and direction to clinical operations.
Thank you. Dr. Dwivedi.
Hello again. This is Roli Dwivedi. I am assistant professor at University of Minnesota in family medicine doc, but my main role is chief clinical officer at Community University Healthcare Center, where we serve very diverse patient population and have been doing a lot of work around COVID-19. So I'm happy to be here and honored to be invited.
Thank you much. Dr. Robbie.
Yes, hello. Thanks for having me. I'm the Chief Medical Officer and a family practice and addiction medicine physician at the Native American Community Clinic. I think that one of the questions was what we're seeing with the COVID, and we are just starting to see, I think, the tip of the iceberg. We haven't had a lot of positive patients yet, but we're sort of like spending a lot of time and energy sort of gearing up and preparing for what we think is going to come.
Thank you. Mr. Harrison.
Oh, hello there. My name is Craig Harrison. I'm the Director of Non-Clinical Operations at the Native American Community Clinic. I am grateful to be here. My role is really managing the people, the processes, and the technology that underpin our programs and keep them running smoothly and enable our providers to be able to serve the community.
Excellent. Thank you, panel. We'll just go ahead and start jumping into questions. And again, audience members, we are here for you. So if you have questions that you're thinking of, please enter them in the Q&A or the chat, and Dr. Allen will be watching for those and bring those up as they come. So some general, just to start us off, Dr. Stately, Dwivedi, Mr. Harrison, and Dr. Robbie, you've all been preparing your clinics pre and post exposure to COVID-19. What are some key takeaways that you've learned along the way? And Dr. Hedberg, also any surprises or insights from the public health perspective in your work with MDH and at the U of M? Let's go ahead and start with just prepping the clinics pre and post exposure. Dr. Allen, you're welcome to join in on this one as well. But Dr. Stately, you want to start with this one?
Sure. I think NAC's response to COVID-19 seemed like fairly rapid. Like that day of March 11th, when the governor sort of kind of announced his plan to sort of like shelter in place everybody in the state of Minnesota, was a real turning point for us. We almost immediately, the following Monday, we had to sort of like figure out how are we going to operate underneath this sort of new normal. We pretty much immediately had to temporarily close our dental operations, because we couldn't, our dental operations is done through a relationship with the University of Minnesota's dental school, and the dental school kind of clawed back all of their providers and also all of their students. So no faculty, no students, essentially meant that we couldn't really run the dental department. So we had to do that fairly rapidly, and that was a decision we made the following Monday morning, when it was pretty evident that we weren't going to be able to do that. And then the next several weeks sort of like were just a series of, what felt like to me at times, just sort of like, one little fire after another. We'd make a decision, then we'd have to pivot and move, and we'd make another decision and we'd have to pivot and move. And I think that first week of March 13th to that whole first week of like shelter in place really was a Herculean effort that it took for the organization to stand up telemedicine and telehealth, something I think that we would not have been able to accomplish without some of the effort that, across the organization we had, but Greg was essential in that. Also my chief information officer and our technology support was really critical in that. But we pivoted very quickly, and we were able to stand up telehealth and telemedicine fairly rapidly, mostly because we had done some things already around previous to COVID-19 to sort of kind of start to test technology and telemedicine last year. That helped put us in a better position, I think. But we've definitely learned some lessons around sort of that specific process, and I think Greg and Kari, Dr. Robbie, as a provider, can talk a little bit about what the implementation and use of that technology has been like, and the acceptability of it in our community.
Okay, let's go ahead and jump to you, Dr. Robbie. Key insights on this process of change? You're on mute. You're on mute.
again, you think I would have figured it out by now. Yeah, so it has been quite a journey, as I'm sure it has been for everybody. I think that being so prepared to get on telehealth right away was so helpful. I think our first, then I recognize looking back, I recognize more looking back than at the time, like our first priority was keeping our patients safe and responding to their needs. And I think that initially the first response was kind of like there was a total like clench response where like everything got very locked down and who needs to be in the clinic and who doesn't need to be in the clinic. And a lot of these decisions were being like, just felt like we were making decisions like every 10 minutes, like another decision to be made, another decision to be made. And we've also really felt there wasn't a whole lot of sort of like infrastructure in place to guide us. And a lot of times I feel like we were almost working backwards from guidelines. If I don't know if you know what I mean when I say that. I think that as far as the telehealth goes, I think our first response was to make sure patients had medications, to make sure that we were addressing the acute needs of our patients and the emergency needs of our patients. So a lot of our providers were actually like doing things from home at night, trying to respond to requests and telephone calls from patients who were anxious and nervous or who had immediate or urgent needs. So like all of that stuff, we didn't have the infrastructure in place to address. I think that like now, like 5-6 weeks down the line, I feel like we're starting to have infrastructure, like our telehealth. We're having processes around how to do a visit, how to bill a visit. When is it important for a patient to come into the clinic? When do they not have to come to the clinic? Sort of balancing the medical needs with the patient's safety. So like, do we really need to see a patient if they have all the signs and symptoms of an ear infection or a urinary tract infection? All those sort of decisions that really fall into the realm in my mind of harm reduction. Like it's like just a very different way of balancing things out. And I can remember saying a number of times those first couple of weeks, it's like you're constantly trying to counterbalance a weight and you don't know what the weight is yet. We were kind of feeling our way. I think we had a very hard lesson, and that I think about, gosh, the time is just all merged together now, but about I want to say 2 to 3 weeks into it, we had 2 of our staff members test positive for COVID. Very asymptomatic, almost didn't get tested because they really had the most subtle symptoms. And then that forced us to really reevaluate our infection control processes and procedures. We thought we were doing a good job. We kind of made some assumptions, but when it came down to it, we recognized we had to send half of our staff home to quarantine at that point. We recognized that initially our first reaction was, okay, who do we need here to do the work? And then we realized that the community isn't going to want to come to the clinic if we haven't really fully addressed and addressed in the most comprehensive way the potential for exposure. So we basically completely shut down to everything but telehealth. And for 2 weeks, we functioned like that, utilizing our neighbors at CUHCCC, thank you, Dr. Dwivedi, and Indian Health Board to give us a backup plan for patients who actually needed to be seen. We had a peripheral laboratory that we used, all of that. And I think that what I learned from that was that the MDH guidelines, are very clear, like what does exposure mean and what does not exposure mean. They have a wonderful chart that tells, what's a high risk exposure, a medium risk exposure, and a low risk exposure. And what I learned from that is how to organize ourselves, and so that if and when another staff member of ours turns positive, nobody has to go home except for that staff member. So that, just sort of recognizing that exposures, you're not going to get exposed if everybody has their masks on, if people are social distancing 6 feet apart whenever possible, not eating in the same room. Well, so I guess that would be my big piece of advice for people, would be to really don't minimize the importance of social distancing in the workplace, and have a really good sort of structured way for staff members to understand how they have to behave in the workplace in order to keep themselves and each other safe and the patients safe as well. Because we did a really good job of protecting with the patients, but we did not do such a good job we still ate in the same lunchroom and things like that. And I know that Dr. Dwivedi at CUHCCC, I'm sure will speak to this, had a really good system for her staff. So I'm sure she can share some more about that. So I think that is know that there are other questions that are on further aspects of COVID, which I think are going to come up. So I think those are the big lessons for us initially.
Thank you, Dr. Albee. That was incredibly helpful. I thank you again. Dr. Dwivedi, Dr. Robbie spoke of a lot of areas that could have used procedure and protocol, and I'm certain that they have some, but I know that you do. Can you speak more to those and to maybe answer a couple of the issues or speak of some of the issues that Dr. Robbie brought up?
Yes, certainly. So learning the key takeaways, the most important lesson that we have learned is the dealing with constant change and unpredictability can be very tiring. So I have been talking with my staff from the beginning about the self-care, which is people forget about it when they implement, and that should be a part from the beginning. We also utilized people or the skills in the clinic. So we had a person who had some skill in the inventory. So we assigned the task of keeping a track of the PPE to that person. So looking at the people who have the right skills and assigning the tasks to those people can help in managing the process better. And so from the beginning, we just implemented a process of screening all our patients. We came up with the screening questions, which were based on the CDC and the MDH guidelines. All patients who entered into the clinic were screened based on those screening. And then we had PPE based on the roles and the responsibility within the clinic. If someone is seeing a patient who is completely asymptomatic, then they will be just having the mask and the gown and the gloves. But if someone is seeing patient who is little symptomatic, then they will be having additional PPE. And if someone is seeing patient who is really sick, then they will have a full PPE, which is a gown and gloves and the booties and head cover and everything. And then you dispose it off after collecting the sample. The bottom line is standardizing the process and having a very clear roles and responsibilities helps in clear communication and elimination of the chaos. I run a huddle every morning, which is a clinic-wide huddle, and a Zoom 3 days a week, which is a provider. And every single morning, I go through what are the expectations of the PPE, what are the roles and responsibilities. We look at the mistakes if they have happened and try to correct them the next day. And the Zoom where all the providers are involved, we look at the process and the flow and the protocols, do a lot of training and the educations. As everything is changing, we implemented a lot of things, so a lot of trainings needed to happen. So we utilize the technology in keeping the staff engaged as we are moving. We also designated a person who is continuously looking at the best guidance, pretty much daily, CDC and the MDH. There are MDH weekly webinars and calls, so they listen to that and they bring that information to me. So engaging with the governing bodies, making sure that we are most updated and communicating that update on a daily basis with the staff, that helps a lot. We send out a daily staff-wide email, which is sent by our CEO. We have a daily managers huddle that helps in, so based on the top to bottom, depending upon the roles and responsibility, there are teams who the same information is processed, but it is processed on a daily basis at several levels, so people are very engaged and they know what is happening in the clinic. And if there is any change, then it is communicated right away. We also have, with this pandemic, has not only brought disruption in the clinical care, but a lot of other things. So we have also implemented weekly HR calls. So I engage with the human resources because there are a lot of other issues that might be coming. So having that in place can be very helpful. If an employee is sick, things get busy. So having those processes and channels in place can help in making it more lean, and it can be very time saving. And then the HR just vets everything with me 3 times a week, and that just helps in structuring things. And then also keeping track of flow, how often you change, because we are changing the protocol. A lot of protocols are getting changed every week to week, but keeping track and logging it, that helps, because if you didn't log it, then you did not do it. and especially we being the university, logging is very, very important. Being, as I said, being creative and smart with the resources, that helps. We used a lot of our dental staff. So as Antony said, that dental clinic was closed right away. We just were dealing dental emergencies, but we trained a lot of our dental staff in being a runners in the clinic, carrying the sample to the lab, or just being a screeners because that they needed to just ask the question. So just making sure that how you engage the team in when you are dealing with the crisis. Infection control definitely has been really big for us. We had a universal masking from the very beginning. Everyone had to have a mask depending upon what roles they are doing. Everyone would have the surgical mask in the clinic. And if no eating or drinking in the patient care area, and social distancing we implemented right away. We moved half of the staff remotely just right away as soon as it was possible. And we gave we created the safest space that people should be feeling comfortable if someone is not using the PPE, being explicit about it, that someone can, if you see someone, then you should tell them that you're not using it appropriately. That has been really work. And then also the one most important things that I want to say, few people should be in charge rather than multiple people being in charge, because if there are too many people involved in the process, it can cause chaos. The other thing that I wanted to say, that the important thing that I learned was that we have to think about the scalability and the sustainability of the process. We changed our process several times in last several weeks, and that can be very, very tiring. There had been time that we were afraid of being inside the clinic. So if reflecting back, I think sometimes there had been moments that we treated it like an emergency rather than a pandemic. But I guess that was the appropriate response. But when I'm reflecting back upon it, we could have thought through a little bit more and could have been just inside the clinic rather than being outside the clinic for a few weeks. That's what I have for now. I think as the questions come up, I will be telling more about in the detail about the processes.
Thank you, Dr. Dwivedi. Dr. Allen, do we have any questions?
I think they'll be better answered a little bit later as we're going through some of the information. I just, as a clinician at CUHCC, I just, two things that Roli raised that I'd like to emphasize. One is the importance of the constant communication, because and through multiple sort of channels, with, you know, because with things changing so quickly, if you miss one opportunity, you need to know that there's another opportunity to hear the information. And the other thing is the PPE. So it sounds simple and straightforward, but the people need constant reminders. And I think that we've, you know, Dr. Dwivedi is doing a very good job about raising that every single time there's communication. And certain people need to really know how, particularly for when you're doing screening or when you're concerned about you're interacting with a probable COVID patient, there needs to be somebody who knows how to handle that and can really sort of guide people through that every time. So it seems straightforward, but it's it's hard. It's hard to get people to do it.
It's hard, and I think also the actual going through it and remembering every one of those steps is another detail that we don't think about in real life until we're in there having to think, okay, do I remove this mask? When do I wash? All those small steps along the way. So I think you're right, that has to be constantly emphasized. Thank you for all of those points. Dr. Hedberg or Sundberg or Mr. Harrison, do you have anything to add to these pieces that you've learned?
Yeah, no, this is Craig Hedberg. I really think the points that were made are fabulous, and the importance of keeping in touch with new developments is really critical, because you know, this event has really highlighted a lot of weaknesses in our planning on a national level and at a state level. But part of the problem is that this is such an unusual event, and what we have learned almost every day, there's new information coming out. You know, the transmissibility of the agent, the shedding of virus before symptoms developing in large droplets, but it's really clear that there's more than just large droplets driving this. And so really being connected to these information flows and keeping in touch with what the State Health Department is doing and what CDC is doing is really critical to modify these responses at the clinic level.
Thank you.
Dr. Owen, if I may, I also agree with everything that's been said, and thinking about like key takeaways, agree very much that COVID is truly novel to all of us, and what I mean by that is the disease has surprised healthcare workers, epidemiologists, scientists. It continues to do so, but that being said, some things also don't change. And so, what we know as clinicians is that good supportive medical care is really crucial in treating people with any gravity of infection. As a hospitalist, I've seen people at kind of the sicker end of the spectrum with this disease as well. And whether we're really checking in on people with low level symptoms of disease, or we're sort of providing the right tools to help people breathe better in life-threatening infections, what we do know is that despite all kinds of new things and all kinds of changes, things that our health system has really learned to do for a lot of different diseases, and a lot of different conditions are still some of the most critical things that we can do during this pandemic. And so that's getting people to the supportive care that they need in health systems.
Thank you. Mr. Harrison, anything to add?
I would just say that, if you were to go back, if I was to go back and tell myself from 3 months ago one thing, it would be to recognize that that this is a stressful, unprecedented situation, and you're not going to get it right the whole time, and to recognize that that these ever-changing circumstances are just to be expected, and you just kind of have to roll with it. And I think so often, obviously, in healthcare, we have processes for everything, and a way, protocols and a way of doing things. And we have had to be willing to learn and make changes very quickly, much more quickly than we are accustomed to.
Thank you, all of you. There are two issues that we need to talk about, and I don't see any immediate questions in the chat or on our question and answer, so I want to jump into them. And I'm going to start, I think, with the systems for sheltering, transferring, and monitoring, because I know that this is particularly important for our northern communities where access is a bigger deal. And while you all as urban people urban providers don't have the same experience, I think some of this will translate as far as the systems that have to be built to make this flow more smoothly. So can you speak to, we'll start with you, Dr. Dwivedi, and Dr. Rabi, but Dwivedi first. Some of our tribal health clinics are far from hospital with critical care capacity, are asking for your recommendations on systems or plans that we should have in place before we begin to see COVID-infected patients. For instance, safety on transferring patients, lines of communication, any other tips you have on being prepared. Even if there's nobody in your clinic yet, you need to be prepared ahead of time so that we don't have these, we can try to mitigate some of this calamity. Any tips on that? Dr. Dwivedi.
I do think so. So typically our clinic is mainly outpatient clinic, but we do see, we were ready, we have, if we are seeing a patient, depending upon the situation of the patient, how sick they are depending upon their social situation, we have some processes in place. So if a patient gets, let's say if I'm seeing a patient who is really sick in the clinic, we have a code process. We call the code and the team responds. They do the assessment and we transfer the patient directly to the hospital after calling 911. Typically, our connections are the University Hospital and the Hennepin Hospital. So that's where we transfer the patient. We know our COVID patient, mainly we were transferring to the hospital, to the University Hospital. And from there, the university has one just COVID hospital, which is Bethesda Hospital. So depending upon the patient condition, they were being transferred to the Bethesda Hospital, which is just taking care of the COVID-19 patients. And so that is one pathway. But let's say if a patient comes to the clinic and then they're experiencing homelessness and they are very sick, but not as sick that they need to be in the hospital. So we do have the care coordinators who developed a relationship with 2 shelters, and then 2 shelters were changed into the kind of hotels where the patients were being transferred and monitored. So that was in place. So if that will be the situation, our providers will be contacting the care coordinators, and the care coordinator will be connecting with that shelter and will try to find a room for them. So those were the 2 things that I wanted to mention, that these things will happen, and having those arrangements, having those collaboration and those relationships, it helps in making things happen quickly, because these patients, they do get sicker very quickly. So having things, having those pathways in place, even though you might not need it, that helps.
Excellent, thank you. Dr. Robbie.
Yeah, so I second what Dr. Dwivedi said. I think that one of the things that we struggle with is our protocol. We do the screening at the front desk, and then we have then for the most part, when people have symptoms, we're asking them to go back home or to call in and do telehealth. And again, for our patients who don't have shelter, we have a special room that where we can evaluate them. And then additionally, we've worked to get telehealth places where people can do telehealth and meet with our providers without having to come into the clinic or be in the same space as our providers. So it's setting up an alternative way to meet with providers for patients who don't have a safe place to be and to do the telehealth. So I think just being aware that there might be some people who don't have like homes and don't have technology and aren't able to access the telehealth like others. We've actually been pleasantly surprised at how many of our patients have been able to use telehealth and do have access to data and to either a phone or a computer that they can use telehealth from. But there's definitely there is that subset of people that doesn't have that, and even though they're a small subset, it's important to have a plan in place for those people as well.
I wanted to add another thing. While the clinic places are getting set up, having a negative air pressure room, that helps a lot in bringing the patient right away into that room. So we do have 2 negative air pressure rooms in the clinic. So as soon as we see a patient has any symptoms, which could be like COVID, we room those patients right away into the negative airflow, and the providers goes with the full PPE to do the evaluation. And that has been really helpful, especially for the patients who don't have the cell phone or who just walk into the clinic.
And we do not have that kind of room. So that's one of the reasons we set up this alternative arrangement. And then we've also we have met people outside on the curb and had conversations with them outside. We've met people in their cars. We've drawn blood in cars. We've done vital signs in cars. It's meeting people where they're at and with what we have. Yeah.
Dr. Sundberg, have, the clinic that you work for is quite a bit more remote. Have they put systems in place? Are they thinking about systems?
Yeah. So, I think, to the sort of question of rural areas in particular, I think I'm reiterating a little bit what others have said, but, thinking about really, really, 1, good communication, and 2, the systems. And what I mean by that is sort of increasing levels of care systems are particularly important right now with COVID. So, you might have tribal or public health systems or a small clinic that can do phone check-ins in rural on patients in rural areas, and for those that are sort of quarantined or they're self-isolating. You might have small rural hospitals that have the capability of providing a little bit of respiratory support, so some oxygen or something a little bit beyond that. And then you have, your regional centers or your ICU that have ICU level of care. And I think one thing and one key strategy in all of this is to really think about mapping those networks. And so really sort of sitting down and thinking about what those networks are and having a sort of plan A network, a plan B network for where patients can go, and a plan C network even. Because the concern being that and we don't know what's going to happen, but if, rural Midwest ends up having a really overwhelming rate of COVID infections, we're going to need to have multiple ways of getting patients to the care that they need. And so I think that, one piece of advice, if I could give, and hopefully this answers the question a bit, Dr. Owen, is really about making sure that that public health systems or folks who are working in public health are sort of helping and communicating with healthcare facilities to create these kinds of maps and really thinking about, if one point is stressed in that network, what other things in the plan B or the plan C that have similar capabilities can be used, and where as a place where you can get a patient to get the care that they need, as quickly as possible.
Thank you. Dr. Hedberg, any public health pieces that you can think of or recommendations that you can think of as people prepare for this to hit rural areas?
Yeah, no, I think the state health department and local public health agencies have been trying to do some coordination, and I think making sure that all of the tribes are in some way connected with those local systems is an important piece of this.
Sometimes easier said than done, but
right.
Yeah.
Yes, very important.
Dr. Owen, this is Dr. Staley. I just wanted to kind of say, I think another companion piece from a public health perspective that we want to try to ensure that that our tribal partners understand the critical importance of. I think one of the things we want to do is making sure that like anything that we can do to assist or ensure that we're getting out information to our membership or to the people that rely on us for that assistance and that support, and specifically information that's accurate, but it's also highly accessible. We also have to remember that not everybody consumes information in the same way. Not everybody can read a document or read an infographic and understand it and those kinds of things. So we have to be able to make sure that we're giving that information so that everybody can consume it and make it as accessible as we possibly can. Particularly under this situation where we're making decisions about how you protect yourself and your family and your community is so highly dependent on a really dangerous contagion, right? A stealthy contagion at that as well. So I think that's really, really important. I think one of the things that we're also sort of like, and I know we're going to talk about this a little bit later, but it's also important that we help people to understand the nature of testing for COVID-19, and then help them understand that a positive test will mean that they're going to need some resources and support that looks like a specific thing. And then when people test negative, helping to make sure that they understand that that test is a test of their status at a moment in time. It's a moment in time, that it's important that they continue to be able to sort of provide, a negative test doesn't mean that you can sort of kind of walk through the world as though you're completely inoculated and don't have any threat. So making sure that people understand the nature of this is really important. And then that ties into also like why contact tracing and stuff like that will be really, really important. And we as a community can do a lot to help our membership and our relatives understand why contact tracing is really important to kind of contain and mitigate transmission and contain the virus, right?
Thank you. Speaking of testing, let's go ahead. Oh, go ahead, Dr. Allen.
Can I just maybe make a link between following patients and then moving on to contact tracing, because I don't think any of us are doing contact tracing yet, but I think that particularly in the rural areas, it's going to be very, very important to keep close track of your patients who are either positive or presumed positive, because as Dr. Dwivedi said earlier, they get sick so quickly, and we've seen that. And I Roli, do you want to share how many positives we have now? Because it sounds like we might be a little bit ahead of NAC. We've
Yep,
had
we do. I do have the data, and I can talk about a follow-up also a little bit. We last night when I checked, I think we had 25 positives so far. And all those are nasopharyngeal or oropharyngeal swab. We also just implemented the antibody testing also. We collected first antibody just yesterday. But what happens at CUHCC is that we have developed a panel, a COVID-19 follow-up panel, which we implemented just in the beginning as soon as it hit us. If a provider sees a patient, and depending upon the testing is done, not done, presumptive positive, positive, that patient is moved just after the visit into that panel for the follow-up. And I have asked our residents to follow up on those panels. So after 3 days, the patient will be receiving a call from the residents, how they are doing, and do the clinical assessment, if they are improving, not improving, stable, unstable, what are their resources, how is their social situation, if they needed any help. And then they will be making a call another time in 7 days and then in 14 days. So we have had this protocol, so there are multiple touches on those patients at a regular frequency and interval to do the holistic assessment of their, not just the clinical assessment, but also their psychosocial assessment. And that has been really helpful. And after 14 days, then those patient gets moved to a completed follow-up panel. So if there is any question, then the providers or the residents can go into that completed follow-up panels and then talk to the patients again. And that has been really helpful. It is the very lean and very easy access for any providers. We know that we have a secured spot where all the patients that we are thinking that they might have COVID, and then they can just go into the chart and everything is available right there. So that has been really helpful. And then for the testing, I'm not sure. I think we're going to spend more time talking about the drive-through testing, and I can talk more.
Dr. Dwivedi, regarding your protocol, does anybody do you have like your chronic people or your people who are more risk? Do they have a different protocol, get called more frequently? How are you handling that?
No, I think everyone, so I think it depends. That's a really good question. So I think everyone gets moved into that panel, and then once you start following up, then depending upon on that day of the assessment, you decide what will be, who will be the next person. So I know that one patient was seen 2 days ago and it was positive. He was quite sick. He was having vomiting and diarrhea. So a touch was done yesterday, and then I did a touch today. I saw a patient, and then I'll be seeing him again. So protocol is a protocol. So I think numbers are the numbers. You can pick up them on numbers, but the clinical care is a bigger umbrella. So I think we're just putting all those patients into that bucket. And then depending upon that moment, you decide if that particular person is needing more touches, because it's very well possible that someone might have a very well-controlled diabetes and they are doing really well, but someone might not have a stable housing and not adequate food or other resources, and they are decompensating even quicker. So I think it depends on like how a person is doing on that particular day.
Dr. Dwivedi, is this one of the protocols that you're sharing?
I will be sharing, as I said, I will be checking all the boxes, and then I'll be sharing everything with you.
So audience, just in case I forget, I want to make sure that everybody understands that the protocols that are mentioned today by Dr. Dwivedi will be available on our website after this discussion today. So Dr. Robbie and Mr. Harrison, can you talk a little bit about the testing approach that you're taking at CUHCC, or NAC, pardon me?
Yeah, so until we didn't have much testing available to us, and we were initially, MDH's protocol was only to test hospitalized patients. So the first few weeks we were following that protocol, and then about, I'd say 3 weeks ago, Mayo was offering has offered testing specifically for the Native American community. and it's free testing. So we gained access to testing at, at will. So at that time, we started to test anybody with any symptoms. We had a partnership with Indian Health Board. They at that time had a lot more PPE than we did. And so we set up 2 testing days, and we opened up testing to all of our patients. We would meet with them on telehealth, and then they could drive through. They still can. They can drive through, and Indian Health Board has a garage underneath their building, so they can drive through. They pull up. We come out in full PPE, test them, and then they can pull out, and then we get the results back anywhere from 1 to 3 days. The benefit of that is we're not wasting PPE. We're trying to keep the wastage of PPE to a minimum. So that was one strategy. Absolutely, we have way less positive so far. Of all of the people that we have tested, except for the 2 staff members, we have only had 2 positive tests so far. We have had patients that have had positive tests elsewhere and have been hospitalized. We've had a couple patients pass away, but as far as the testing that we've done, we've only had those couple positives. We also responded to a request from a shelter to come and test when they had some positive testing, and we tested 45 people at that time, and that was kind of an interesting in that we were testing people that didn't necessarily have symptoms, which is kind of stepping a little bit outside of the protocol that MDH has set forward, but it also was still within the guidelines that Mayo had set forth to do testing to protect the Native community. So we did do that, and that was interesting. We did not have a lot of. We only had 1 positive in that testing event. So it's very interesting for me to hear Dr. Dwivedi talk about their processes. The processes that we put in place for our patients is to check in every couple of days with positive patients. We are also developing. It's not complete, but in the meetings in the morning, we're developing information for patients on how to care for themselves at home. We're using the information that the MDH has put out. We've also put together information on pulmonary hygiene, like doing some coughing and sort of spirometry and things like that. And we're counseling patients on that, and just based on things that we're all learning. There's obviously no established clinical protocols around that. And sort of giving patients information on when to call, when to be concerned, and have looked at things like spirometry, but have not spirometry, I beg your pardon, pulse oxes, but have not been able to secure those.
Thank you, Dr. Rabi. I want to ask Dr. Harrison. I know I see the question, Dr. Allen, but I want to ask Mr. Harrison, do you have anything to add to what Dr. Rabi said, and then we'll get to Dr. Reynolds' question.
Yeah, so I would just say, there are quite a bit of digital infrastructure that we found really helpful to get set up really early on. So the ability, obviously, to do a telehealth visit, but also, getting folks registered digitally. So that's a process we had always done on paper. And to be honest, it was actually a lot easier to transition that process to being online and allowing people to do it remotely than we had expected. And so really exploring those pieces, because, trying to keep as many folks out of the clinic, even for the for the referral to testing has really been helpful for us. We also, and also just the experience of rooming a patient, which is something, we're all very familiar with what happens when a patient comes into the clinic and how we room them. But that process, figuring out what your workflow is going to look like and who is going to do what when that transitions to being a digital rooming is really something to get figured out, because as you're trying to screen patients and refer them for testing, or just really any sort of primary care visit, like really understanding who is doing what and what that's going to look like, is going to be really helpful, because it is not a natural process when you first start doing it.
Thank
especially
you.
as you start to scale that up.
Thank you. That's helpful. Dr. Allen, do we have a question?
So we have, I think, a first question is what about testing asymptomatic people, which I think was touched on, but maybe you can talk about a bit more. And then some reservations are testing them. Also, what criteria do you use for antibody testing?
Dr. Dwivedi, go ahead.
Yes, I can talk about it. We are still following the MDH guidelines that we should be testing the symptomatic patients. But to be honest, I'm not strictly following that. It depends on case to case. We had several patients who work into the companies or small businesses where they are asking them that you cannot return to work until you get tested. And I don't want anyone to be without job or get laid off in this situation. So we are just taking it case by case. Yes, test when they are symptomatic, but if someone's is at risk of other things, then we are testing. So I know we recently have tested several members of a family because they work in different, like a bakery or other, doing a personal care assistant to someone. So then based on those criteria, we are testing. For the antibody testing, we just started the antibody testing just 2 days ago. And the reason that I brought the antibody testing is it's a good test. We are doing the university test. It's a very sensitive, very specific. It's 99% sensitive, and 97% is specific. But if you look at go to the MDH website, or if you even look at the detail in the test, it doesn't give you any clear guidance when or who should be tested. The language is just very loose. I just got the test just because a lot of employers are asking that they should be tested. And also, as the state is slowly opening up and the elective surgeries will be happening, so some of the surgeons will be asking the antibody testing to be done before the surgery is performed. So those are the two criteria that we at CUHCC that I just decided. I have not come up with a full guidelines. Reached out to the MINAC, which is the Minnesota Association of Community Health, to see if there are any other national guidelines that we can adopt. But we looked at the CDC and the MDH, and there are no clear guidelines for the antibody testing so far.
Dr. Robbie probably has something to contribute because we've been doing some of that work.
You mean in terms of the antibody testing?
Yeah, well, no, in terms of we've made some exceptions to testing non-symptomatic people under certain circumstances, and I think it's helpful if you describe what that.
I think it's challenging because as actually as Dr. Stately said earlier, there's a lot of education that comes with testing. Like, what does it mean when you test positive, and what does it mean when you test negative? And really there's not even a well understood false positive and false negative rate. So it's sort of trying to explain that to patients. And so every time that we counsel somebody with a negative test, we also counsel them they should continue their isolation. But we still follow the MDH guidelines, which is 7 days from onset of symptoms, plus 3 days from when you start to feel better, don't have a fever, whichever is longer. And so even though you have a negative test, that doesn't mean to relax your isolation. And I think that the biggest utility of the testing for somebody who's not very ill is in encouraging them to continue to isolate. I've called people to give them their test results, and they answer the phone and they're at the dollar store. There's so that ongoing education around what does it mean to isolate, what does it mean, who are you protecting, and why all of those pieces are so important and need to be said over and over again for our patients and our staff, as Dr. Dwivedi said. So I think that's really the challenge of the testing. We've done a lot of testing for people who are very anxious and looking for reassurance, for sure, but have mild symptoms, and we are following the guidelines, but we are also being very relaxed in who we test.
Can I add one thing? So at CUHCC, we have created a letter which automatically is given to the patient as soon as you collect the sample or if you are screening them. So that letter says it's for 10 days. so that it is available if they needed to give it to someone at work, or and it does talk about the isolation. We also developed a smart text in Epic, where all the, because I mean, I'm not entirely sure where those tests will be going, but if they go to the MDH or any other lab, there are certain questions that are required. So we have created a smart text in Epic, which has all those questions, so that we are not forgetting to collect any data.
Yeah.
Dr. Robbie, it looks like you want to add something, and Dr. Hedberg, I know you've been waiting, so go ahead, Dr. Hedberg.
Yeah, no, I think one of the areas where testing asymptomatic people has been recommended is in like long-term care facility when there are multiple cases, and recommendations are made just to go in and test all staff and residents to really get a handle on where the virus is within the facility. And there's, you know, that's an application that could also be put into, say, a homeless shelter where you're trying to evaluate a group exposure. I really want to get a handle on at this point in time, you know, who all in this setting is infected, and then you can use that information to help manage what you do next in that facility. In terms of the antibody test, right now, you know, the antibody testing is it's going to be useful when we start seeing the data in aggregate. But the predictive value for an individual right now is really low. And so, you know, the problem with doing antibody tests on an individual is that we don't really know how to tell them what that means. It's not clear at this point whether that really confers protection from reinfection, or whether if it does confer protection, if it's going to be a lasting immunity. And so I think, you know, there are a lot of studies going on right now to try to look at antibody both as a measure for how widespread the virus may have moved through our communities, but then also there are people just trying to do the studies to figure out, you know, how can we interpret this and can it be interpreted on an individual.
Thank you, Dr. Hedberg. Dr. Robbie, did you have one last point? And then I think for the interest of time, because we promised people 1 hour, I'm going to wrap up and try to address these 2 questions that are remaining. Go ahead.
Yeah, no, I think that I lost that thought, but I was thinking with what Dr. Hedberg said. Well, you know, it was like we really are struggling with this thing of like how testing people in treatment facilities, and what's, you know, we're really lacking some guidance in what that means and how to interpret that. Like we have been discouraged from, you know, they don't follow the guidelines to get tested, but they're very vulnerable. The people who are there, a lot of times there's chemical dependency and other risk factors, and so we've sort of stepped into that situation, and I think that what we are learning in this whole situation is in so many of these areas there isn't a lot of official guidance, and you are kind of making things up as you go along and trying to follow sort of the principles of what you've learned as you practiced and as you've developed your profession, but it's very difficult to know exactly what the right thing to do is in any given situation. So becoming very uncomfortable with the uncertainty of that.
Thank you. I think you've all pointed out, it almost feels like we're first-year medical students again in some ways. That balance, I think one of you highlighted nicely with that analogy to the balance, just not knowing how to weigh anything because it's all in the air, and this has completely stumped our experts who we can normally turn to as well. But it sounds like you're doing great jobs of developing some protocols that we will post on our website. I wish that we had gotten a chance to address some really important issues like Dr. Allen has brought up, what she has been seeing as far as increasing rates of mental health issues and mental illness as a result of COVID-19. And I think that's an important topic that hopefully we'll be able to discuss in the future. There are also a couple of questions addressing or asking about the disparities between tribes for testing between states, and then even I think within the state, and then also questioning the federal and state response to tribal needs. And they're incredibly valid and important questions. But this intent of this panel today was really to get some expertise from folks who had seen this disease in the cities or in another tribal clinic somewhere else, and bring those to our rural folks who this has fortunately not yet hit and hopefully won't, but to help with some preparation. If people still want more of those questions, yeah, thank you for anonymous attendee asking us to do this again. That was my next point. If there are more questions that you would like answered and you found this helpful, please do state so on the poll that'll be at the very end of this, and send in your questions, and then we can get the appropriate people on the panel to answer those questions. Thank you to all who attended, and especially thank you to our panelists. I want to reiterate that we will have those protocols and this video available, this recording, at med.umn.edu/CAIMH. And if I could get one of our panelists to type that into the chat, that'd be terrific. We are going to leave the chat up for a few minutes so that you can enter your questions.
I wanted to just tackle that one question that one of the tribal leaders asked about, specifically with respect to the availability of tests, and that has been probably a challenge. I know that certainly was a challenge that NAC had very early on, even the challenge of getting PPE and those things. And obviously those two things go hand in hand critically. Like I think one thing that you want to think about when you're thinking about, like, do I test asymptomatic people or not, is also the availability of PPE. Like, you don't want to be using up your PPE supply or your test supply on people who are asymptomatic if you don't have a robust supply structure. The other part of that is that their tribes should be able to work directly with the State Emergency Operation Command Center to requisition PPE and also testing. And if your tribe is not connected to that SEOC and people doing those coordinations, and that's certainly something that took a while for us to find out as well. That will help sort of like move things along more systematically and rapidly. And what I found useful was I contacted the governor's office and pitched a fit. So, and I got a meeting.
Great, that's all gonna come from this little webinar. Thank you, Dr. Staley. All right, excellent. Thank you again, panelists. And we will leave the chat open for a little bit so people can let us know what they were most interested in. And thank you all, and good night.
Good night. Thank you.
Thank you.
Kirsten, please stay on with
you.
me, and anybody else who wants to discuss this after. All right, I don't think participants are gonna mind if we just go ahead and discuss any thoughts, anything we need to. It sounds like we will probably do this again from the response. And does anybody have any thoughts before we, I mean, we're gonna look through the chat and find other questions that people have, but any other thoughts or perspectives we could bring to the next one? Michele, particularly you.
Well, I think we have a few more questions that we can get to.
Yeah, that went pretty fast, didn't it?
Mm-hmm.
1 hour. Yeah. I'd really love to hear more on that mental health, and I think that our community would as well.
Yeah, I was gonna, after that person raised that question, I was wishing that I had Dr. Meyer, our Director of Behavioral Health, on the panel, because I think one of the things that, obviously, that we're seeing, and we've been seeing in a significant uptick since COVID-19 hit, and the shelter-in-place orders, is just increases in domestic violence reports, child abuse reports, just the amount of level. I mean, you know, I'm a well-resourced individual with a stable home and a 6-figure salary, and I sometimes want to throttle my children beyond recognition, because it's so frustrating, right? To be able to be sort of like, this is challenging for everybody, and so people who are very unresourced, don't have a lot of resources, might have lots of challenges and things that we need to support them with.
It's very difficult for our patients who are already struggling with mental health or chemical dependency. It's like so many doors are shut in their faces. And one of the things that we recognize is that if, admitting to symptoms can be a barrier to resources. So that becomes a whole nother challenge.
Yeah, there is definitely that catch-22, isn't there, that we've been hearing about with this disease, letting people know you're positive, but yet needing the services, right?
I think there's also this just level of fear and pervasive fear and anxiety in the community. And I recently had somebody from the community, somebody that kind of a colleague who works in another organization or in a community partnership, call me and was like, somebody in our community has tested positive, and we have families who are anxious, and that person, in the interest of trying to sort of like be transparent, posted that information on Facebook, and then people sort of like really jumped in and listened to that person on Facebook, and and this person was an elder, and it was like trying to help them. Like she was like, I don't know what to do. How do we help? And I just basically said, like, I think a really good way of managing that is to help people to understand, like, we ought to be telling people in our community that they should expect that everybody that they come into contact with this could be positive. You should behave and conduct yourself as though they are. And then also trying to reiterate and remember to reinforce, like, Indigenous principles, like we want to be good relatives. We want to hold people close, and there's ways we can hold people close and support them without actually having to share physical space with them, right?
I would also want to say that we can take this this pandemic as an opportunity to engage a lot of our patients or the communities who have been denying the facts of their brain health or the neurological health, and we can use the telemedicine. Because at least I can speak for CUHCC, our primary care visits are down, but the mental health visits are 100%. So I think this is an opportunity to reduce the stigma and engage the families and the communities to provide and have access to mental health care. And the other thing that I wanted to say is that we have been seeing a lot of increased CPS cases, especially for the families who are experiencing COVID and are not able to take care of their kids. So that's also has been, we don't have any solution for that, but I think we need to talk about it, and we need to come up with I think we need to push the system somehow so that the things can be available.
We've seen some issues with foster families just abandoning children that they're caring for out of fear of COVID.
Holy smokes.
Mm-hmm. One talk that I just heard today that was actually really helpful, and there might be some ways to think about getting somebody who could speak well to this in Native communities, but was a developmental pediatrician talking about how to talk with, how parents can talk with kids about this issue, because, and how kids are processing this so much more than we really realize, and are affected by this a lot of times so much more than we really realize. So, just thinking about if you almost wanted to create one that was really dealing with mental health
yeah. How about one committed to mental health and another to peds, and another to elders? I don't know. Are you guys willing to
Chemical health. Don't forget chemical.
Yeah. I think NAC has a developmental psychologist, child psychologist that we now have on staff. We could provide some support around that. I think Dr. Robbie's done a lot of family medicine and pediatric work.
Dr. Robbie, what did you say though? I didn't hear you.
Chemical health.
Yes, yeah.
Because access to resources around chemical health has gone down, like the availability of safer use supplies, how people do MET, like suboxone and methadone is challenging.
And I would add, if there's any administrators on the call who would appreciate a separate call to talk about some of the programmatic pieces of all this and all of the pieces and parts that have to come together to support these initiatives, I think that, I would certainly be willing to be on that panel.
Yeah, I have to say that the infrastructure that Greg and his team have put in place that have allowed us to do the clinical work has been so important. We felt like fishes out of water for quite some time.
So how about if we plan on another one that addresses mental health, chemical health, and has the pediatrician piece in it? I worry that it's going to be too much again, but let's try. I think we could try to do that one and then do another one more on programmatic infrastructure. What do you guys think? Or should we break it differently? Michele, what do you think? Okay.
I might recommend that you do like mental health and chemical health in one.
I would agree.
Peds and families specifically.
Peds and
I
family.
think the peds and family pieces could
Okay.
definitely be its own.
And then
Okay.
potentially
We're
just
looking
like
for.
taking care of people's like chronic health, you know, just like taking care of like, well, like how do you continue to provide good care to your community in the context of the COVID, like with all the everything else going on, like making sure kids are getting care and elders and everything.
With the pediatrician and families one.
Yeah.
Yeah.
And if you wanted to do a chronic disease management, I think that might be another one, because there are, speaking from CUHCC, I know we are doing a lot of panel management on diabetes and the asthma specifically, but how do you do that? That can be another thing that we can talk about at some point.
I can do a workshop on kicking governmental ass. I'm just kidding.
Well, we'll all attend that one. I think given that, you know, these other issues, it would be good to, especially with the mental health and the chemical health, to get someone actually from our tribal communities in the rural area to come in and talk, because they've already started to see this piece as well. And there's no reason that they wouldn't share a lot of really good information for us as well.
Yes.
So I'll try to find someone for that panel. And then for the peds and families, maybe the same thing, have some of the same experts from the cities, but also grab someone who has seen some of the stress that we're seeing even without COVID in the rural communities on the panel.
We do a tribal echo, and we could potentially reach out to some of the people that are participating in that around the chemical dependency piece if you're interested.
That's fantastic. Okay. So I will start, I'll probably start a Google Doc, and if you guys feel, and then put under mental and chronic health, you guys add any experts you think should be on that panel. Same for peds and families. Michael, if you would be in on the peds and families one, that'd be great.
Sure.
Chronic illness, and then programmatic infrastructure. Again, I think maybe doing a mental illness and chemical health, then another programmatic infrastructure might be nice. Then families and peds, and then chronic illness if people are still attending these.
I just thought of something I was going to say. Forget it now. Oh, Dr. Robbie and Greg, maybe on the information or the resource page for at the end of this, we can put information about our Tribal Echo project on there, so people can get tied into that on a regular basis.
That's a good idea, because I think not everybody knows about the echoes yet.
Yeah, absolutely.
Cool. Well,
Anybody wanna keep talking
I got
over
another
the-
call in about 5 minutes, 10
Okay.
minutes. Believe it or not, with the governor's office. So thank you so much. I really appreciate being invited to this table. You guys all did amazing work. Thank you.
If anybody else has anything to add afterwards, please share them on the Google Doc or just email us. And thank you all for your help.
Bye.